Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today on the podcast, we have our normal regular guest, our medical director, Rob Dixon.
Good afternoon, Casey.
We have a special guest today. We have one of our MCHD district chiefs, April Currie.
Hey, guys.
And today, we love that Dr. Dixon and I receive EMS patients here in Montgomery County most of the time. We've done several Monday morning quarterback episodes, and y'all, the listeners, like them, and we like doing them. Every now and then, though, for me, when I get the super sick ones from y'all in the field, it's pretty nerve-wracking being under the microscope of multiple paramedic eyes. I, just like y'all, want to perform. I want y'all to trust in my medical ability. We do so many educational things and training and scenarios and CEs. If I go in and drop the ball, that there's a level of trust there, a level of confidence that I feel very, very passionate about, and I want to make sure that that's reciprocated. It's human nature to want to succeed in those situations, but not everyone's going to go smoothly, no matter who's watching. And so this was one of those struggle situations. I was lucky to have Chief Currie in the room to help me wade through some pretty serious road bumps in this case. So without giving it away, April, how did the call come out for you? What did you know? And how did you prepare as you were getting ready to arrive on this call?
Okay, initially the call was dispatched as a priority 2 call, so it really didn't alert me to go to the call. It didn't add me to the call initially, but it was one of my crews. I read the call notes. It just, a patient having possibly an allergic reaction. That's how the call came out. So kind of routine, didn't seem like anything crazy. So I just decided to add myself to the call and show up. So I was a little bit after the crew. I arrived a little bit after the crew. They had already had time to make patient contact. So en route to the call, I really didn't have any preconceived ideas. I thought it was going to be pretty basic, just
kind of run-of-the-mill
allergic reaction.
Sure.
Yes. Mm-hmm.
So you arrived on scene and quickly realized that it was a good thing that your spidey sense said, I need to hop this call, huh?
Yeah, and I think the crew was happy too. So, I just walk into to the residence, and they're actually had already put the patient on the stretcher, was strolling down the hallway, and I see the crew, and I can, they're my crew. I could kind of tell they felt a little bit of relief, like, hey, you're here, and so as they around the corner, I see the patient, and very surprisingly. Changed my thought process about this patient and the significance of it.
What did you see that made you? It was pretty obvious. This wasn't a needle in a haystack.
Right. So the patient was somewhat responsive, but the very first thing you see was her mouth. She had extreme angioedema. Her tongue was protruding out of her mouth. That was the very first thing that I saw on this patient.
So now you're in transition from residence to the truck. You've got obvious severe angioedema. We know what goes on your differential. Fire some of those off for us.
Yeah, it goes, number one for us would be allergy. Was there anything else with allergy? Is there a rash? Is there a known allergen? Is there a history suggesting some sudden onset after some allergen? Is there vomiting or GI symptoms? Have a listen to the podcast we did on this. I learned a ton from it. The other thing, probably one of the more common, is ACE angioedema. So it can happen with angiotensin receptor blockers as well, but it's mainly with ACE inhibitors. But these are meds like enalapril, ramipril, something that ends in pril. And it's a complex mechanism, but essentially they can't clear their bradykinin and they develop angioedema. It doesn't have to be right after they start the medication. They could be on the medication for a number of years. The last one, which is I've only seen a few times in my career, and most of the time we're lucky patients know the diagnosis is they have a C1 esterase deficiency. They have a hereditary disorder that causes this type. And the other types would be traumatic or a traumatic burn, or I've seen it when the patient bit their tongue, had severe angioedema. So those are kind of the differentials in order of that they occur. I'd put trauma up beneath allergic, and then, it would be ACE, allergic, trauma, C1 esterase.
Yeah, the other I'd fire in there just for listeners' sake. Other times I've seen it. There's two more for me. Infectious causes, abscesses. Anytime you think about
and malignancy,
swelling,
I left out malignancy.
Yeah, malignancy,
well.
And then for those of you out there that listen that are in transfer services that transfer patients on TPA on Alteplase, which is becoming less and less common with the movement of TNK and single dose TPA into the world of stroke care. Folks that get TPA, Alteplase specifically, can get pretty significant angioedema. So that's one where if you see that in your transfer truck, you turn the TPA off. The really weird thing about TPA-associated angioedema is it's often contralateral to the stroke side for whatever reason. And that, to me, is just bizarre. But anyhow, that's a pretty good rundown of the differential. Mm-hmm. You asked and brought the patient in with really most of those questions answered. Take the easy ones first. There's no trauma, so trauma is not an issue. There's no history of malignancy. There's no history of hereditary angioedema. So y'all really focused pretty heavily in on anaphylaxis and ACE angioedema. Mm-hmm. So where did we get with those two? Tell the listeners as you tried to peel back the layers, what'd you find?
Well, we did have very limited information for this patient anyway. Just didn't have a lot of information. Even the onset was a little bit skewed. Like the caretakers were a little vague about when it started. So the onset, I think, for a lot of these things is important to know. And kind of help with the differentials, but we just had very limited information. So initially, the crew had immediately just went with some type of allergen based on the fact that the med list, which is what, that's the first thing I asked, like, where's the med list? Let me see the med list. So they had pulled up the epi and started that route at initial contact.
Really good call.
Yeah.
Really good call. Just remind listeners to have a listen to that podcast. The number one reason people die of anaphylaxis is we either don't give epi or we give it too late.
So yeah, the crew did a really good job pulling the trigger on that soon, but then we're kind of at a loss too. So with with her tongue swelling, it looked like maybe the side of her face was swelling as well. So they were just pretty lost about like what is happening, because there was nothing that really, it looked like angioedema, but what's the cause? How do we know what happened? So at that point, we were just getting some vitals, getting to the ambulance, and her blood pressure was cycling, and of course it came back at low. I believe maybe 70 systolic was the initial blood pressure.
So we addressed that with push dose and.
We got push dose, yes, and then we started an epinephrine drip.
Perfect. And this is a case where if we're going to go back to our pressor protocols and our recent changes here, we've pretty clearly defined that norepinephrine is our pressor of choice, except in cases of bradycardia and anaphylaxis. Anaphylaxis would be on the list for this patient for sure. So moving from push dose epi to drip epi was totally a reasonable thought process. What'd y'all have from an airway standpoint? Market angioedema. What were your airway thoughts on scene as you were getting ready to leave?
Obviously, be prepared for the worst, because with that, we're going to have some roadblocks, if we have to manage that airway. Now, this patient, fortunately, was oxygenating okay in the 90s. We had oxygen saturations in the 90s with the patient not being in like distress, like no obvious distress as far as respiratory distress. So just a sick patient overall, but and initially they wanted the patient transported to a facility further away, and so that was the decision. I said we can't do that. We're going to go to the closest facility, manage this patient. And so at that time, our priority was kind of managing getting the patient hemodynamically stable while being prepared for airway compromise.
Which would have been a surgical airway in this situation.
Exactly.
Probably no ifs, ands, or buts, huh?
Yeah, no way that we would have tried to paralyze this patient and without, other resources.
Now, Chief, was there any other findings on the clinical exam that would lead you to an allergen? So any rash,
No.
any wheezing, any
No.
GI symptoms at all?
Nothing.
That is a tough one.
Super
It's a tough
weird,
one.
yeah.
With the swollen face, I think your infectious gets a little bit higher. So still out there. And did you notice a Prill medicine or an ACE inhibitor on the med
No.
list?
And that was the first thing I looked for. Is I looked at the med list, looked for rashes, any of that. The facial swelling was kind of big for me too. Like it wasn't just her her
Yeah,
tongue.
usually it's just lips and tongue.
And it looked like the side of her face. And actually, even in the call notes, it said, her jaws looked swollen, and it was just like the right side of her face. So just super, super unusual with no findings of like how this started, where it came from.
So thankfully, I was staffing the closest hospital to
Yes.
this unfortunate patient.
He's being very cheeky.
It was when they rolled through the door, I saw the same thing that Chief Currie saw when she walked to the bedside. It was no ifs, ands, or buts. If not the worst angioedema on the top 10 list, if we're going to do a David Letterman top 10 list, it was on the top 10 list of my worst angioedemas. I mean, her tongue was just visibly protruding. So I knew that definitive airway was going to be a challenge at best. And then to try to back into patient stability and a differential, this was just exceedingly complex. So I wasn't exactly sure which direction to go, honestly, because there were so many unanswered questions.
I've only had a couple of similar ones like this, and I took the same approach that April did, is I treat empirically. If we don't know, I think it's safe to treat empirically for allergy, and I did the same thing. I gave IM epi, I gave the other stuff that doesn't matter, and then I put the patient on an epinephrine, a dilute epinephrine drip, and kind of prayed that it would get better, and sadly in one case it just didn't. It's definitely emergent, definitely have patency problems. What's your game plan?
I first and foremost, I agree with April. Her airway, for however long it was going to be, there was no signs of patency loss. It was just patency pending, and it was a second-by-second situation. There was no stridor. There was no hypoxia. She was altered, but not in distress, I would say.
Right.
She wasn't able to really follow commands. So I knew that while I would say in that second when I first saw her that her airway was grossly patent, I didn't feel confident that it was going to be patent in 30 seconds later. So I always try to operate from a differential diagnosis-based progression, but this is one where, honestly, I had no clue. I scoured the list for an ACE inhibitor or an ARB or something, and it wasn't there. There were no other signs of anaphylaxis, and our crew, thankfully, had been very aggressive with anaphylaxis treatment and had seen no real improvement.
Yeah.
So I doubted anaphylaxis just because my general thought was, even if it was severe anaphylaxis with epi drip and no budge, I sort of honed in on the facial swelling, the asymmetry there that pointed against anaphylaxis for me. So I said, okay, I think, I don't know where we are here. I'm not sure what it is. Is this some sort of infectious situation? But what flipped this case on its head was there was just the obvious severe tongue angioedema. So I sort of changed from my normal process and said, I've got to act, and we'll figure this out later. So we've got to get the blood pressure up. We've got to get full monitoring in place, and we've got to get a surgical airway set up ready. Like, that's what we have to do first. I can't intubate her yet or even try without having some hemodynamic stability, because I'm going to be going from plan A to plan C more than likely. If we can't pass an endotracheal tube, we're going to be doing a surgical airway. So we started with push dose. We started with vasopressor drip. We started with fluids and continued exactly what our crew was doing in the hospital setting. And it took probably to get monitoring into place, to get the surgical setup, to get suction and RT ready and nursing staff ready. I tried in my most calmest manner to explain to everyone, this is not a walk in the park. We have to have every I dotted and T crossed. And of course, the patient had difficulty getting all of our vital sign data appropriately. We had trouble maintaining a SAT. We had trouble getting blood pressures repeatedly. So just like y'all in the field, it happens sometimes. You want all those vital signs. You want the heart rate, the blood pressure, the respiratory rate, the end tidal, the SATs. And of course, in this case, because it was going to be insult to injury, I struggled to get all the vital sign pieces into place, and the folks in the room were sort of pushing for action. I wanted to act, but I said, we can't do anything till we know our blood pressure's good, till we've got a reliable SAT pleth in place. And that probably took us, my memory timer is always at risk, but I think that probably took 5 to 7 minutes, which seemed like an eternity looking at the tongue the entire time. So we'll roll into some of the real life struggles during intubation. And this is the part where hopefully y'all listeners understand that there are difficult airways that are difficult airways for anyone and everyone. And I'm not sure, maybe this is ego talking, but this one would have been tough for anyone. This was as tough of an airway as I've ever had in the hundreds that I've dealt with over my career. This is, if not the toughest, it's on the medal stand for sure. So first and foremost, my plan was to start with video and to try to be as set up and prepared and have the patient as pre-optimized as possible. And that went pretty well. We had access. We had a really functional IO. Thank you all. That was really excellent to have, because we struggle with peripheral access due to some other issues in this patient. And the tongue was enormous, past the blade, was able to just absolutely clearly see the chords on the screen very quickly. There wasn't much difficulty on attempt 1 with seeing the chords. It looked like the chords were in a tunnel as opposed to the big open cavern that usually is the the hypopharynx and the supraglottic area. It was like looking through a tunnel to the chords. And so I attempted what we teach. Attempt number 1 was with a bougie. I actually went with a bougie only, just due to space concerns. And of course, you run into every possible, no pun intended, hang up in a situation like this. The tube just hung on the arytenoids, and I tried 90-degree twist, 45-degree twist. I tried ramrod, everything, and I could not get the tube off the arytenoids. So I pulled the tube and said, I'm going to go bougie only, no tube. And then, of course, the bougie hangs on the first tracheal ring, just like, it's like every single thing that can go wrong here goes wrong. And twist, turn, maneuver, I could not get the bougie off the first tracheal ring anteriorly. So I've hung up posteriorly and anteriorly, and the SAT started to drop at that point. And so we pulled everything and went to bag. So by that point, I was dripping with sweat, clearly frustrated because we could see the cords. I got the tube right at the arytenoids. I got the bougie through the cords and failed, really 2 failures within 1 there in that first intubation attempt. So we bagged back up, and I said, all right, if that didn't work, let's change equipment slightly and see if we can have better luck with the rigid stylet. So switched out to a rigid stylet. Does that sound like a reasonable approach to you? Would you have done anything different?
Yeah, let me back up and ask you, what did you sedate with, and did you use a paralytic? Because I know we've kind of differed on our approach to these particular type of patients before, as far as paralysis versus sedation only intubation.
Sedation only.
Okay. Yeah, that's what I would have done. I have one that I went with paralysis. Dr. Patrick and I have talked about a couple of years ago that I thought could have gone better, and if I had to take back, I would have just sedated and made sure I could could have a look or some modicum of success before I paralyzed. Once you take away that respiratory drive, it could be a race to the bottom pretty quickly.
Well, this is one where if
patients.
she had been moving or if she had vomited, I would have wished I had paralyzed her. She did not. She did not vomit, and she did not move or thrash at all. So we got what we wanted out of that. I was ready to paralyze if I needed to, but I really honestly thought my chances were probably, from a pretest probability standpoint, pretest success, I thought I had 50-50 chance at best. So in that situation, I was, in my mind, just as committed to a surgical airway, which was not a thin neck. There was swelling in the face. I wasn't 100% sure what I was going to be cutting into. So there was that piece of the puzzle too. We were able to bag back up pretty easily. There wasn't a whole lot of complication there. Is that how you remember it,
Yeah.
Chief?
Yeah. I mean, I think it seemed like once we could get past the tongue, it looked different, but it seemed like it wasn't going to be that difficult, especially when you were sitting there just like, what is happening? Why isn't this budging? But yeah,
that's the hardest part of it, is because it really did seem like I had it straight away.
Right, yeah.
Like single attempt, single pass, right at the cords, and whether it was a tube hanging or the bougie hanging, that attempt 1 was very stressful. Attempt 2 with the rigid stylet, honestly, I don't have any other great explanation here other than to say I missed it. The cords were just as visible. There was no bleeding. There was no new swelling. There was no vomit. It looked the same on attempt 2 as it did attempt 1. I just missed. I passed the tube and retracted the stylet, and there was no end tidal. So that was a pretty quick. It must have just, slid posteriorly into the esophagus. I don't have a really good answer other than I missed. So back to the BVM, and then we start to bag the patient, and it gets really confusing, as if it couldn't get more confusing or more stressful. The patient is on a finger pulse ox that we were using. We were having some confirmation issues. The patient was on the hospital monitor, and the patient was on the defibrillator monitor. So we really have 3 monitors in place. And the pharmacist says, hey, the heart rate's in the 30s. And I had the surgical airway set up, and I said, all right, hand me the scalpel. And the nurse says, no, it's in the 60s. So I'm looking at the hospital monitor, 68, the defibrillator monitor, 39. And
did you have a SAT at that point, or?
We had a SAT and a heart rate on the finger probe that was in the 60s, heart rate, SATs of 92. So at that point, I honestly wasn't thinking with my 100% clear mind. I mean, I was absolutely frazzled. This was uber difficult. I would love to say that I was cool, calm, and collected and really taking an itemized, stepwise approach, but it's just so frustrating when you can see the cords and you know where you've got to go. You've been there hundreds of times, and it's like there's an invisible wall there. Mm-hmm. So I made the quick, maybe correct, maybe incorrect, I'll let you chime in, but I said, all right, I'm going to go with a tiebreaker. The finger probe reads heart rate in the upper 60s with a SAT of 92. The hospital monitor reads the same thing. I have no idea why the defibrillator monitor is different. I didn't really take time to look at the morphology and to see if there was some sort of double counting or some other issue going on, or half counting. I don't know that
anybody would have had the state of mind to parse hairs, but I would say that's real life though, right? All we have is the patient, and we have our data, and sometimes those match and sometimes they don't match. You have to make your best assessment, which I think you did, and I think I would have gone with you. If I had 92, knowing they're not going to die from 92, and I had a heart rate in the 60s, and I had been able to successfully rescue before with the bag, I would have believed my rescue, and I would have tried to change equipment or change something before I went to surgical. Knowing that there's that fine line, you want to wait and give them as much chance for success, but understanding that Dr. Patrick and our service here, as you go from first attempt to second to third, your probability of successfully placing an airway from above goes down, regardless of provider that's doing it. And it's a crapshoot. You just have to make the best decision you can at the time. And I think that was probably a reasonable one.
I asked for the scalpel at one point and turned around, saw the monitor, hospital, saw the finger probe, and sat it down and said, I'm going to take one more look. It's just really hard for me to pull the ripcord on a surgical airway when I just saw the cords. It's so much easier if you're unable to get into the mouth, if there's so much blood, vomit, crushed face, burn, whatever it is. If I can't see the cords at all, there's only one way to get there. But if I just had the device in my hand and I could see the cords, it's really hard to make that incision. And I elected to attempt one, a second chance, and I went back with the bougie, and thankfully, smooth passage, felt the rings, positive end tidal, passed the tube easily. Third time was a charm instead of a strikeout in this case, thankfully, and I immediately needed to change my shorts. Really the best part of it is the calmest person in the room was standing beside me, and that was Chief Currie, and that goes a long way to keeping the situation calm. I wasn't yelling or stomping. Internally, I was very frazzled. Externally, I'm sure I was moderately to severely frazzled, but it was really excellent to have one of our folks right there beside me who knew exactly the stepwise process that I was going down. I was trying to practice what I preach here, and even in those tough situations, I'm going to get nervous too. So in the end, sometimes it's better to be lucky than good, and I took all the luck I could get in that situation and was very happy. But it was definitely one of the most stressful airways that I've had really ever. So I was thankful to have some good help and some good hands. And, the RT, the pharmacists, the ED nursing staff, the MCHD crew that was in the room, we had a really solid crew of people in there who were doing their jobs, closed loop communicating, working together. There wasn't friction or back and forth or other than my own that I created. The rest of the team did really an excellent job. So I couldn't have done it without any of those folks, and leads us into the what happened portion as we wrap up. I followed up some in the hospital chart, and it seemed like all of the consultants who saw the patient were concerned about all of the same things I was concerned about: infection, anaphylaxis, some sort of idiopathic angioedema. So no clear cause was found at the point I last looked. And this is a situation where, from a learning point standpoint, we have to act without complete information. We have to act without a clear differential diagnosis winner a lot of times. And that can be a thing that locks all providers up, is the need to know prior to acting. And that's just not possible in the job that we picked. So with that patency hanging off the cliff, in the end, it didn't go the way I would like it to go. We're not going to put that one up on YouTube for a learning video by any stretch of the imagination. But we got where we needed to go without significant prolonged hypoxia or bradycardia. And so I feel like that was a success, even though it wasn't perfect. So let's wrap it up.
By the way, doctor, you just did put that up on YouTube.
No, I mean the video of
I'm
it.
teasing
no
you.
one's watching that one.
I'm just taking jabs at you. I couldn't resist. I'm sorry.
Yeah.
No, this is a good one. I mean, these are the ones that we need to be talking about. It's super, super hard. And I'll echo what Casey says. When I get to be and work with our people, it makes me feel better to have them in the room.
Oh,
It
I was
absolutely
relieved to
does,
see
because
Dr.
we
Patrick.
train the same way, and hopefully you see us practice what we preach here.
Definitely, yeah. It is a relief to walk in and see you guys, for sure.
Next time you walk in, it can be just a belly pain. I'll be fine with that. Get me a CT scan, get some pain medicine.
I'll stand next to you every time.
You can we can do a little slow pitch next time. That was a 101 mile an hour slider. I wasn't hitting that one. No way, shape, or form. Wrapping it up. Sometimes surgical airway may be plan A. It may be plan B. Have to be ready. Have to have your equipment and know your steps. Fortunately, we didn't get there in this situation, but close as I've been in a while. Setup, preparation should be standard, should go without any real second thought. That should be true front brain material. where your setup and your suction and your maximal oxygenation, your NP-OP airways, your IV access, your push dose pressor mix, all those things. We talk about those all the time on the podcast. But in situations like this where you have a giant weight on one side of the scale that is angioedema, you don't want confusion or frustration or, oh, shoot, I forgot this one thing, when your scale is already so laden with the big weight of angioedema. It's hard to perform a surgical airway with visible cords. I know I've been in run reviews with medics. I've been in discussions with my partners. This is probably the first time that I've ever gotten close to a crike where I could see the cords and couldn't get anything through them. So I realize now that's a really difficult decision, and that it's easy to sort of grab onto the fact that I can see it. But if the patient decompensates, it doesn't matter what you can see. You have to be able to pass the tube through said cords for it to be beneficial for the patient. So if you can't get there for whatever the reason, you have to still be willing to move to the surgical airway. And lastly, we got to sort through difficult, disconcordant, discombobulated, unclear, muddy, murky information. And in that situation, my thought process was, all right, I'm going to have a tie break here somewhere. I had two monitors saying one thing and one saying another. So that's the way I used my mental scale. We're going to have to do that in ways that we can never really describe. The next call that you run, Chief Currie, may involve some situation you could never even come up with. But the hard part about our job is using that incomplete information when it is incomplete to still make a decision to go forward. So thank you all for joining us today. Thank you all for wading through the muck on this one with me. I appreciate it. Anything you want to add before we close out?
Great case. Great job, guys. And really, really good by the crew. Great differential. Great early treatment. You know, and in this one we may never know. And that's the frustrating thing about some of these cases of angioedema is really deep down, we may never know. And we don't know, and I'd argue we don't know in a lot of these patients. They just get better.
Well, as always, thanks for joining us here on the podcast. If you have feedback, questions, ideas for future podcasts, email us at podcast@mchd-tx.org. Leave us a like. Leave us a review wherever you listen to your podcast. Subscribe. Subscribing to the podcast is important, so I'm going to add that to my end of the cast spiel here. We want to listen. We want more listeners. We want to grow. We love your all's feedback when it comes our way. We've gotten several podcast-related questions over the last month, so the back-and-forth engagement is why we're here and why we do it. Thanks for listening. We'll be back with a new episode soon.